Gagandeep is joining.
He told he will join.
Dr. Gagandeep, I can see him on in the attendee list.
Okay.
He's there. He's not. No. Sorry. No.
I saw him.
Good evening. Good evening. Yeah, just there was something I was stuck, so it's a bit late to join.
Hi, Soham. How are you?
Good evening, sir.
Good evening.
I think we'll start with the introductions and then the session. It is already 8:01.
Yeah.
So very good evening and welcome to the first session of this Controversies to Consensus, which is a online debate-based webinar series. As we understand and as we know, there are gray areas in all parts, all aspects of the science and as well as in neurology also. And that produces both a diagnostic as well as a therapeutic dilemma in our day-to-day practice. So considering these problems of day-to-day practice and to overcome some of these controversial issues, we thought of starting this webinar series, which will discuss especially the controversial topics in the common areas of neurology. That is stroke, epilepsy, movement disorder, and headache, which are the common areas which we come into the practice in day-to-day OPD practice, and sometimes we are faced with dilemma of what to do. So this is some of these areas we will be covering, and we will try to reach the consensus through the debates and through the expert opinions. So there are 4 conveners for this webinar series. It will run for the 1 year. Stroke topics as well as the stroke series will be coordinated by Professor Dr. Saileja from the Sri Chitra Tirunal Institute, and we are very grateful that she agreed to convene and this take forward the stroke part of this series. Movement disorder will be covered by the Soham Desai, eminent movement disorder specialist in the country, and headache section will be convened and as well as will be coordinated by Dr. Sanjay Prakash, who we know that's one of the most prominent headache experts in the country with largest number of publications in the headache. So with this introduction to the first session, the first session today is on epilepsy, and we have chosen a common topic which produces a dilemma in day-to-day practice about what should be the initial monotherapy in patients with idiopathic generalized epilepsy. So whether to choose valproate or levetiracetam, these are the common choices we have. And to debate these areas, we have eminent epileptologists from the country, Dr. Jayanti Mani. She will be speaking on the role of levetiracetam and will be advocating the use of levetiracetam as the first monotherapy. We all know Dr. Jayanti Mani, one of the prominent epileptologists in the country, at present attached with Kokilaben Dhirubhai Ambani Hospital, and extensive experience in epilepsy and drug-resistant epilepsy. And another aspect will be covered by Dr. Dinesh Nayak, another prominent epileptologist from the country, who is a teacher for majority of us who are practicing epilepsy, and one of the prominent clinician and epilepsy expert from in the country. So I welcome both Dr. Jayanti Mani and Dr. Dinesh Nayak, and thank you for agreeing to debate these issues. Then subsequently after the debate, we'll have an expert panelist. Unfortunately, Dr. Radhakrishna is not able to join today, so we have Dr. J.M.K. Murthy, one of the senior most neurologists and epileptologists in the country, who has been the past president of the Indian Academy of Neurology, as well as the past editor of neurology in India, and everybody knows he's a great academician and clinician, and we will be benefited with his wisdom and his knowledge about this medicine, about this topic. And we have another panelist, Dr. Gagandeep Singh. I think he needs no introduction. He is a president of the Indian Academy of Neurology, and he has been past secretary of Indian Academy of Neurology, a avid researcher and clinician with more than 200 publications and world-renowned authorities in neuropsychosis and other aspects. So this will be discussing this. So I would initially what we'll have is a poll from the audience. Okay, what is their preferences for which drug do you prefer as initial monotherapy in unselected patient with genetic generalized epilepsy or idiopathic generalized epilepsy? Choice is levetiracetam, B is valproate, and C if you want to use another drug. So I will request admin to start the poll, please. Okay, so you can, apart from the host and panelist, everyone can poll.
I was quickly trying to punch in.
No, that will be biased, no. So that is why it
The
has been
host and
disabled.
panelists
Then-
cannot vote.
Yes.
There may be cross voting, so you know.
So we will give you 10 seconds for this poll. You select your option, please, and we will display the result after 10-15 seconds. So if everybody has voted, then we can show the results, please. Okay, so I think there is a bit of advantage for the valproites, but I think Dr. Jayanti Mani will try to persuade people that it may not be valproate. So around 69% and 31%, nobody is going to use any other drug except valproate and levetiracetam. So we can close this one, please, and I will let the duel begin. So I will invite Dr. No offense, please. So I will invite Dr. Mani to put forward her views and the initial monotherapy in genetic generalized epilepsy.
Thank you so much, Chaturbhuj. I thought the audience will actually choose levetiracetam, but they haven't. So I have a case to make here. Can you see my screen now?
You have to share it, madam.
Yeah, I thought I have shared. Just a minute. Just a second.
Yeah.
Is it visible now?
Yeah, visible. We can
Yes.
make it a slideshow. Yes.
Yeah, so thank you very much for this opportunity to discuss therapy in genetic generalized epilepsies. I think a few years ago we didn't have too many drugs and there was not much choice. So I think now we are spoiled for choice, and luckily today we are limiting our debate to just 2 drugs, and that makes life a little easier. Otherwise, there are more than 5 or 6 drugs now available, which is a good thing. But taking this whole debate forward, I am going to be speaking in favor of levetiracetam, while evidence may, from trials seem for the contrary. So just to put things in context, what is genetic generalized epilepsies? There's been a lot of confusion about terminologies in this area. There is a overlap the way idiopathic generalized epilepsies and genetic generalized epilepsies are being used. But in 2017, the ILAE has attempted to clarify these terminologies, and the big umbrella term now is genetic generalized epilepsies, where the person will have any one or more of the 4 types of generalized seizures. That includes absence seizures, myoclonic seizures, primary generalized tonic-clonic seizures, or myoclonic leading to tonic leading to clonic seizures. So any one or more of these types is what the patient normally has. And the EEG usually shows a typical spike wave pattern whose frequency can vary from 2.5 to 5.5 Hertz, and it's generalized in distribution. While the pedigrees may suggest that there could be a genetic etiology, still the modes of inheritance are quite unclear and they're often polygenic. And it affects about 0.1% of the population. So when you look at this whole big umbrella of genetic generalized epilepsies, under it, you have also what is called the idiopathic generalized epilepsies. Apart from this, there's an overlap with certain other rarer syndromes, like a myoclonic epilepsy with abscences, or epilepsy with eyelid myoclonia, or a much more, grave but rare syndrome like myoclonic astatic epilepsies. These are, there's a continuum, and these are not watertight compartments. But within genetic generalized epilepsies, we discuss the group of idiopathic generalized epilepsy syndromes. And under this, we have 4 included, that is childhood absence epilepsies, juvenile absence epilepsy, juvenile myoclonic epilepsies, and epilepsy with generalized tonic-clonic seizures. Now, what is common in all this is that usually they have an age-specific age of onset and peaking, and often they are quite mild in the sense that tonic-clonic, generalized tonic-clonic seizures are infrequent, and usually these patients have normal cognition, and the epilepsy is initially quite drug responsive. And 80% of the epilepsies, if one of the broad spectrum drugs are used, these respond to drugs that are from the broad spectrum group. We'll quickly go through what these are. And if you just look at the age spectrum on the cartoon on the left side, you can notice how there is a certain age range in which childhood absence occurs, juvenile absence occurs, juvenile myoclonic, and mostly in the adulthood, that is what we adult epileptologists deal with. We are looking at juvenile myoclonic epilepsy and a much smaller proportion of tonic-clonic seizures alone, and even lower proportion of juvenile absence epilepsies. Now, the other aspect, apart from all this, is the fact that there is a strong female preponderance in genetic generalized epilepsies. In fact, this nicely done study looked at the percentage of women in both these cohorts, one cohort with genetic generalized epilepsies versus another with mesial temporal lobe epilepsy with hippocampal sclerosis. They found that 65% of patients in the GGE group are women, as against exactly about 50% with the MTLE group. So there's a disproportionate representation of women in the genetic generalized epilepsy group, and this is something we need to keep in mind. Also, when we look at the positive family history in patients with genetic generalized epilepsies, there too, there is a slight emphasis on more women being there within this group. So coming to the medications, we have a very broad spectrum of medications available: valproate, lamotrigine, levetiracetam, topiramate, zonisamide, brivaracetam, and recently added perampanel. Now, it appears that irrespective of the medicine we choose, they all seem to respond well to the initial therapy from when we choose one from this group. But the important thing to remember is that even though they may be controlled quite well, even with the first drug, all these patients need a long duration of treatment, because every time an attempt is made to take off medications, there is tendency to relapse. So apart from lifestyle that you recommend, you often recommend that these patients take the medications even if it is at low doses for very long periods of time. And as we just saw, that since the epilepsy starts at a very young age, this can span almost majority of their lifetime. It is true that we don't see a lot of genetic generalized epilepsies in the older populations beyond 50 and 55. So there is some natural remission, but in the most productive years, they do need to take medications in most cases. So then when we look at medication and choice, there are two terms one needs to remember. One is, of course, the efficacy. That is how well the medication controls the various seizure types that are part of that genetic generalized epilepsy syndrome. So when we look at those drugs, the seizure types, we are looking at absences, myoclonic jerks, and generalized tonic-clonic seizures. And between the two, we know that the spectrum for valproate is good for all three drugs, whereas levetiracetam may not be as good for absence and also marginally not as good for tonic-clonic seizures. Now, when it comes to tolerability, that is another important aspect one looks at when one is making a choice of drug, especially when we are looking at medications taken over a long period of time. So when we combine both efficacy and tolerability, then we are talking about the effectiveness of a drug, and which is best measured by looking at how long somebody is retained on a particular treatment. Apart from these two aspects, that is the safety and the efficacy, there are so many other day-to-day, housekeeping kind of issues that come up when we are using drugs for a long time. One is the ease of use, pharmacokinetics, the protein binding, the drug interactions, how well they can be used when there are other comorbid diseases, what about emergency use, and finally, even the cost of the drug. So all these parameters also make us, help us in making our decisions. Now let's look at some evidence here. And most of these control trials, I must remind you, do look at the efficacy of the drug that is being compared with the control or with the alternative drug. So in terms of head-to-head comparisons, there are very few trials that are available, but the landmark trial was the most recent one. That is the SANAD-2 trial, which was completed in 2021 and compared levetiracetam to valproate. They used an open label model, and it was a randomized control trial. And it was used as to see how levetiracetam fared as against valproate as a first-line therapy for patients with either generalized or unclassified epilepsies as well. So all these were grouped in one umbrella. There were about 520 patients and fairly equally distributed between the two drugs. And interestingly, they used 500 milligrams twice a day of valproate and also 500 milligrams twice a day of levetiracetam. The age group was rather wide, and they had quite a few children. The median age was just 13.4 years, and there were only 35% of these were women. So the primary outcome was to look at the time to 12 months remission, and based on all these parameters, they were not able to establish that at the non-inferiority of levetiracetam, meaning that valproate did score better, the remission rates were better with valproate, and they did a cost-effective analysis and then said that valproate was better than levetiracetam. Interestingly, when they looked at adverse events, they report that there were more adverse events with valproate than with levetiracetam. And at the end of this, they decided that valproate was superior to levetiracetam in terms of efficacy and cost effectiveness. Now, when we look carefully at this study, there are a few points I would like to make. Sorry, just a minute. Just minimize this. Yeah. What we notice here is that the proportion of men to women in this group was really skewed in much more in favor of the male gender. Now, we need to keep this in mind when we just looked at that other study, which told us that in fact, 65% of patients with genetic generalized epilepsies tend to be women. So you need to keep this in mind. And also, though we looked at all types of syndromes, there was a disproportionately low number of juvenile myoclonic epilepsy. And in fact, 26% of their patients had childhood absence epilepsies. And while you all will all agree with me that even in the general, population, we do not have this kind of a skewed representation, even if you take children versus adults, of absence versus juvenile myoclonic epilepsy. It's in fact JME that is the most common type, even if you adjust for age. So it appears that the cohort that was studied was not the very well represented one, though they did attempt to make it as best as possible by doing an open label study. Also, they mentioned in the paper that there was an automatic exclusion of women in the childbearing age to use valproate because of regulatory restrictions. So even among the women that were there, quite a few of them were not put on valproate because there were already regulatory restrictions on using valproate. And in fact, 10 pregnancies were documented, and all of these were in the levetiracetam group. So it is not surprising that they did not report any malformations or any kind of pregnancy-related complications in this study. And also, they claim that there were psychiatric problems in as high as 109 patients with on levetiracetam. But even in the valproate group, they seem to have found quite a few with psychiatric disorders. And unfortunately, we do not have much details on what exactly these problems were, because they have used a format which just groups them according to the systems. They do not have anything to record things like tremors or endocrine abnormalities like menstrual irregularities. There's no mention of what they mean by skin and subcutaneous tissue disorders. So it is a very, the adverse event profile doesn't seem to have been detailed specific to valproate, while they have actually studied only valproate versus levetiracetam. So there is a great detailed study of psychiatric disorders, it appears, but not so much of all the other typical side effects with valproate that one would be worried about. So those were the little points that I wondered whether they skewed the cost effectiveness evaluation. Now, when we look at some other papers, this is a study that looked at clinical features and treatment outcomes of juvenile myoclonic epilepsy patients. And again, compared valproate and levetiracetam. This was as recent as 2019. And what they found is that among the 105 patients, an equal number were on valproate or levetiracetam, and 85% did well on monotherapy. There were 42 women, and 78% of these were only treated with levetiracetam. And when they compared seizure types and the effect of valproate versus levetiracetam, of course, in the tonic-clonic seizure group, valproate fared better. But in the overall comparison, when all seizure types were included, there was no statistical difference between how valproate and levetiracetam fared. And again, you must notice that in this group, the control group used about 556 milligrams of valproate, and amount of levetiracetam used was not much more. When we know that in real life, we use much higher doses of levetiracetam because one can tolerate up to 3 grams, whereas one would never consider using those high doses of valproate. So in all these studies, it seems like the dose adjustment for valproate was much higher than what they were using for levetiracetam in terms of equivalence. So though, yes, there was a trend towards a little better effectiveness of valproate, we need to keep all these factors in mind when one is studying these papers. So, and then interestingly, when they looked at the well-controlled group versus the not so well-controlled group, it appears that there was not a much big difference in the quality of life when it came to controlled versus uncontrolled groups. And that is not surprising, because even in the natural history of all these disorders, the most disabling seizures, that's the tonic-clonic seizures, are anyway the least frequent. So seizure control does not seem to affect the quality of life to that degree as one would expect in, say, a focal epilepsy with refractory seizures. So this is something we also need to take cognizance of. Now, this is a third paper that looked at, it was actually a study from a country consortium that was studying genetics in a variety of disorders, and they culled out the patients with juvenile myoclonic epilepsy and then compared the responses to valproate, lamotrigine, topiramate, levetiracetam, and carbamazepine. And when you look at, they have evaluated multiple of them, but when you see valproate versus levetiracetam, the initial monotherapy response was 42% for valproate and 37% for levetiracetam, and this did not reach any statistical significance in terms of the difference. And when we looked at valproate versus levetiracetam, the adverse drug event rates were much higher for valproate. With levetiracetam, the main problem was the behavioral one, whereas with valproate, there was weight gain, there was tremor, there was even cognitive issues with valproate, and also lethargy that was reported. So the number of side effects and the spectrum of side effects was definitely much more in this study that looked at 305 patients with juvenile myoclonic epilepsy. Now, as regards absence, there is a clear evidence that Levetiracetam does not do as well as valproate. And in fact, in this study, when they compared 158 patients, which is probably one of the largest, 72 were treated with levetiracetam. And but they detected fairly early on, because of the high frequency of seizures, that about 25% of them did well, and the rest of them had to be discontinued, and 60% of this was due to lack of efficacy. So in this group, maybe it is true that levetiracetam scores better in terms of, because there's a disproportionately higher number of people who do well on valproate. Coming to the side effect profile. Now in women, now we just saw that genetic generalized epilepsy in young girls and in women is much more common. But this is where valproate has all the problems. Causes hormonal problems, polycystic ovary syndrome, hyperandrogenism, that means weight gain, hirsutism, insulin resistance with irregular periods and infertility issues, ovulatory failure, the works, polycystic ovaries and tremors, apart from all these endocrine related problems. And believe me, one worries about anxiety and irritability with valproate, with levetiracetam, but I wonder, when a young girl is faced with so many of these issues, I'm not sure whether she's going to be in a great frame of mind and not have, appropriately so, be anxious and, depressed because of these kind of side effects with valproate. So, in fact, what has been shown that when you compare even doses less than 650 milligrams of valproate and levetiracetam as high as 2,500 to 4,000 milligrams, the major worry with valproate is the risk of major malformation during pregnancy. So you can see that even at lower doses, as low as 650, levetiracetam does much better at much higher doses, and the odds ratio is as high as 2.43. And this is from a very comprehensive registry, that is the URAP registry, that looked at more than 8,000 patients. So clearly here, valproate seems to score much lower than levetiracetam. And here, when you look at the registry more closely, you can see that the rate of major malformations is 2.8 with levetiracetam and as high as 10.3 with valproate. In fact, there has been a decline in the number of major malformations in pregnancies in women with epilepsy between 2000 and 2013. And that has really mirrored with a decrease in the use of valproate in women. So I think that just speaks for itself as to, what kind of a problem valproate was causing. It was a silent killer because malformations don't cry out. We don't have symptoms related to them, and you don't realize what is happening until we are faced with the problem. In fact, not only the malformation problems, there have been other issues, as we all know, with valproate, that if you use it in women who are pregnant, it not only causes malformations in 10%, but in as high as, you can see here that the IQs of children, when it was measured at 6 years, was much lower on valproate compared to carbamazepine or phenytoin or lamotrigine. In this particular study, of course, there was no comparison with levetiracetam because it was done at a time when levetiracetam was not being studied systematically. But in a more recent paper, which has looked at 9,000 children and looked at the exposure to valproate and the risks associated with it, you can see that the hazard ratio when compared to lamotrigine, which has a very low risk, it's as the hazard ratio for neurodevelopmental disorders is 2.7, for pervasive developmental disorders as high as 4.4, and mental subnormality is 3.1. Whereas when it was compared to levetiracetam or many other drugs, there was no increase in the risk of any of these neurodevelopmental adverse outcomes. So there again, not only the kids that are born with malformations, it can also affect the IQs of children at a much later age. So because of all this, it's not what you and I debate. It's already been decided that valproate use should be banned in women and girls, especially in the UK and also in Europe, unless they have been put on a very active pregnancy prevention program. And the ILE also has now instituted guidelines that valproate should be considered in women only after they have failed to attain seizure control or treatment alternatives. So now when we are discussing initial monotherapy, which is the topic of the debate today, I think it's very clear that valproate is definitely not the initial drug in women in whom genetic generalized epilepsies are the commonest, are much more common rather. So I think this is enough and more evidence. Okay, there is some concern about using levetiracetam and psychiatric symptoms, and it was supposed to be about 7.8% in a very large cohort of more than 1,000 patients. And even in this study that looked at a variety of drugs, it is true that levetiracetam had a higher risk for behavioral side effects, but it seemed to occur more in people. There are clear cohort which showed this, and they were able to subgroup them. That is, if they have a prior psychiatric condition, if they have frequent secondary generalized seizures, they did not look only at genetic generalized epilepsies. It looked at patients with also focal epilepsies. So if there are absent seizures, if the epilepsy is intractable, or if there's an underlying static encephalopathy. Now, so this would be not so difficult to screen, and you all will all agree, intractable epilepsy is not a discussion in our cohort. So we are looking at initial monotherapy. And when you look at the incidence of the kind of side effects, the main problem is irritability. Dangerous side effects like anxiety and depression were only seen in 3%, and psychosis and suicidal thoughts in less than 1% of patients. So you can take some precautions to avoid this, because behavioral issues, there's some evidence that using, pyridoxine supplements may help. And we may be able to do some screening for mental health issues before we initiate levetiracetam. So we also find that there is a, sorry for that, when there's a multi-center cross-sectional study that was done in India across many centers, and if you look at the group with generalized onset epilepsies, clearly there were more people using levetiracetam compared to valproate. So I think that itself speaks that even common sense prevails, and when you look at way things are used, valproate is being used at a much lower frequency as the initial drug of choice. So to summarize, I'm going to say that, before I come to this summary, and there's one more point that I wanted to make, and that is that apart from all this, there is also the risk of using a drug when there are other comorbid issues, when there is other, drugs to be used along with levetiracetam, or valproate, because these are given for long periods of time. And we'll all agree that drug interactions or comorbid disease, one can use levetiracetam with so much ease, can be also used in emergencies. So even from a day-to-day ease of use, I think levetiracetam scores much better. So I would like to summarize here by saying that genetic generalized epilepsies constitutes about 10% of all epilepsies. It starts early in childhood or early adulthood, and JME and other unclassified generalized genetic epilepsies form the bulk of patients in young adults and middle age too. Women constitute more than half the patients, and 60% of patients are controlled on the initial monotherapy irrespective of what is used. But treatment periods are long, spanning decades, and will also include periods of childbearing. So chronic side effects and teratogenicity concerns do become an issue. So though valproate has been shown to be marginally more efficacious than levetiracetam, the spectrum of side effects are quite chronic and serious, and many of these, like malformations in pregnancy, are not reversible. So the ease of use in terms of drug interactions and comorbid diseases is also better with levetiracetam. So hence, levetiracetam, I think, scores as a clear winner as the more effective drug for initial monotherapy in adults with genetic generalized epilepsies. We can use, easy psychiatric screening tools to make sure that patients who are prone to behavior side effects can be, kept away from this drug. And that would be much easier to do than to ensure that a person who's on valproate is suddenly taken off the drug just before pregnancy, tried on something else and put back on that drug. All that doesn't sound practical to do.
Okay,
So
ma'am.
hence,
I think
yeah. Thank you.
we can conclude that. Thank you very much. You passionately debated and advocate the use of levetiracetam. I think major issue which probably you have highlighted is that although you considered that valproate is more efficacious, probably valproate has more side effects, and especially in women of childbearing age. Those were the two, I think, the major points. Apart from you highlighted many other points, I think we will debate on that. So I will invite now Dr. Dinesh Nayak, sirs, to put forward his views and why he thinks that valproate should be the drug of first choice. Sir, 20 minutes.
20 minutes. Yeah, thank you very much for that very kind. It's a great privilege to be here for this debate. I thought I'll get the first chance, but I didn't get. And looking at, hearing Jayanti's very persuasive arguments, I think I'm going to find it a bit difficult to. I've almost become a valproate, a levetiracetam person now, so my gloves are off. But let me try and see whether, after this very persuasive argument for the use of levetiracetam in the initial monotherapy in patients with genetic generalized epilepsy, let me see whether, there's still, I have the audience backing with me. So I have about 60% of our audience who's in favor of valproate. But after listening to Jayanti, I'm sure many of them would have now kind of having second thoughts. But let me try to bring them back into this game of why, valproate is still the #1 drug for genetic generalized epilepsies. Now, valproate has been there for many decades now, and it's been for a long time. It's been recommended as the first-line treatment for generalized and unclassifiable epilepsies, mainly because it's a broad-spectrum drug. But for many decades, from its time it was introduced for treatment of epilepsy, evidence was lacking. And if you look at the Cochrane database, 2000, when it was compared with phenytoin, they concluded that there's no evidence to support the choice of valproate for generalized epilepsies. But there were some issues, methodological issues, etc., misclassification, etc. But that was the conclusion. So they really did not have, although they kind of mentioned that, yes, it is a good choice, but there was no evidence. And similarly, a year later, we found no unequivocal evidence to overthrow or support the use of valproate for generalized tonic-clonic seizures. Now, that was the state of the art at, just when levetiracetam was just coming into the market. But that kind of changed a little bit when the SANAD 1 in 2007 studied the effectiveness of valproate, lamotrigine, and topiramate for generalized and unclassifiable epilepsy. And this was a randomized controlled trial, unblinded. And they compared those patients with generalized epilepsy where they thought that valproate would be the first-line treatment. They compared valproate with lamotrigine and topiramate, and then they found that very clearly that valproate prolonged the time to treatment failure as compared to lamotrigine or topiramate. You can see that graph very nicely there. And also for it reduced the time. It reached the remission time, 12-month remission time, much faster than lamotrigine, but not for topiramate. So it was as efficacious as topiramate, but so the conclusion was that valproate was better tolerated than topiramate, but more efficacious than lamotrigine. And they interpreted that valproate remains the drug of first choice for many with generalized and unclassifiable epilepsies. But again, as Dr. Jayanti has pointed out, because of the adverse effects in pregnancy, the benefits of seizure control in women of childbearing years should be considered. I mean, this was in 2007, so much has changed subsequent to that. But it just this is the first randomized controlled trial that showed that valproate is the first choice for generalized and unclassified epilepsies. Even before that, we knew that valproate is a good drug for that. Now, levetiracetam came into the picture, and it had a lot of positives when it came in, because it was a broad spectrum drug, good for focal, good for generalized, good for myoclonus, good for adults, good for pediatrics, easy to administer, short titration period, multiple modes of giving the medication, administration, convenient dosage, well tolerated, good safety profile, few interactions, safe in pregnancy, very good for OP, IP, emergency, ICU, popular with neurologists and non-neurologists. And so how does valproate now compare with this wonder drug in generalized epilepsies? Then came the SANAD 2. I'll spend a little bit of time on this study of the effectiveness and both clinical effectiveness and cost effectiveness of valproate versus, so this was a head-to-head comparison in newly diagnosed and generalized and unclassified epilepsy. So this was again a randomized controlled trial. It tried to compare the clinical efficacy as well as the cost effectiveness of levetiracetam versus valproate in newly diagnosed, generalized or unclassified epilepsy. And this was designed to assess the non-inferiority of levetiracetam over valproate. And that was the primary outcome. The primary outcome, I'll tell you now, it's a phase 4 study, which means, that it's already approved drug. You're studying 2 approved drugs, multi-center, multiple centers. So that means, it is across the country as such. And as Dr. Jayanti had already pointed out, quite a few of them are much younger. So 5 years or older, at least 2 unprovoked seizures who have never been treated earlier. And it over a 3-year period, 3.5-year period, and they were followed up for minimum 2 years. So that was and the outcome measures, the primary outcome measure was time to 12-month remission. That means from the time you start the drug and from the days of randomization to the first day from which the 12-month period of remission has begun, so elapsed. So that is the first, that's the primary outcome. And it has been designed in such a way. And then you have the secondary outcomes where time to 24-month remission. So that's important. You can see that it is not, they studied also the 24-month remission, time to the first subsequent seizure. And then they also studied the secondary outcomes for treatment failure. That means, the treatment failure can be either because of inadequate seizure control or because of unacceptable adverse effects. So these are the outcomes that you can have. As Dr. Jayanti pointed out, the initial dose was actually pretty small for lamotrigine. For levetiracetam, it was only 500 milligram twice daily, but the initial dose of valproate was pretty high, actually, 500 milligram twice a day. So that's a bit skewed. I thought, yes, that's true. And but the other one is pretty good because levetiracetam generally it's about 40 to 60 milligrams. So they started at 40 and valproate at 25 milligram for children. But it's important, it was not just at that level. I mean, the subsequent dose changes were made based on the treatment response and in accordance with routine clinical practice. So it's not that they were maintained only at that dose. Levetiracetam dose was adjusted to ensure that there was no, there was no treatment failure. Now, this is the arm that we are looking at, the arm B, actually, the generalized or unclassified epilepsies, 520, 260 in each group, valproate and levetiracetam. And this is the non-inferiority design. And when you have, so on this end, the hazard ratio is 1 here. So on this side, the right side is valproate is better. And on the left side, levetiracetam is better. So, and they found that this is the limit, the non-inferiority limit at about hazard ratio of 1.3. So anything that falls beyond that is clearly valproate is superior. Beyond this, levetiracetam is superior. And if it falls between 1 and this 1.31, then levetiracetam is non-inferior. That means it is as good. But if it is beyond this 1.31, then levetiracetam is inferior. So this is how it has been designed. And so let us look at the outcomes. The primary outcome here is time to 12-month remission. And levetiracetam was not non-inferior to valproate. So that is the first outcome, which means that it failed that non-inferiority test. And you can see here that the percentage of patients with immediate 12-month remission, that means as soon as you start the medication and then how quickly these patients went into remission. And so that was clearly superior for valproate as compared to levetiracetam. Time to treatment failure, which means that, the treatment failure, the definition is that, it's either inadequate seizure control or adverse effect, whatever it is. So again, here you can see that valproate was clearly superior to levetiracetam, undoubtedly. Time to agreed. I mean, this is also highlighted by Dr. Jayanti, treatment failure due to adverse events. There was really no difference between the two groups. So that was there. But then you can see that, and this was also pointed out, that the psychiatric side effects were, adverse events were more with levetiracetam. The weight gain was more with valproate. So it kind of evened out, but the psychiatric it was definitely much more with levetiracetam, without doubt. Again, treatment failure due to inadequate seizure control, and this is very important because when you're giving a drug and it's not working, then that's one of the problems. So this is valproate was clearly superior to levetiracetam, without a doubt. So, and the time to first seizure was again, valproate clearly scored over levetiracetam. So on multiple accounts, on parameters, valproate was clearly superior. And you can see that, over the long term also, time to 24-month remission, again, valproate was superior to levetiracetam. And the cost effectiveness also, they found that, there was more savings in the group. This is the NHS data, so a bit complicated, but I don't want to go into that. But this is the NHS data that clearly showed that there were more savings in the valproate group as compared to the levetiracetam group. So the study concluded that, at each endpoint, the primary endpoint of time to 12-month remission, levetiracetam was not non-inferior to valproate, which means that it's favoring valproate. Time to treatment failure, valproate was superior to levetiracetam. Treatment failure due to inadequate seizure control, again valproate. Time to first seizure, valproate better than levetiracetam. Time to 24-month remission, again valproate better than levetiracetam. Treatment failure due to adverse events, no difference. So that was without a doubt. Now, based on these parameters, you can actually clearly conclude that valproate is the most effective drug for genetic generalized epilepsy. Although this is, we are only talking about the initial monotherapy, but there's a very interesting aspect when you consider genetic generalized epilepsy. And there are, a group of patients who have genetic generalized epilepsy who unfortunately do not respond very well to medication. So that is there. And so what happens to this group, and we just look at this, this is to define the clinical predictors of drug resistance in genetic generalized epilepsy. And they studied about 137 patients, and they used in these patients the broad spectrum appropriate anti-seizure medicines that we generally use: valproate, levetiracetam, lamotrigine, and zonisamide, topiramate, and the benzodiazepines and phenobarbital, primidone, etc. They found that 33 patients, which is about a fourth of patients, were drug resistant. And they found that those patients with psychiatric comorbidities, age at onset, that means younger patients, juvenile absence epilepsy, absences, they were associated with worse seizure control. And then the interesting part is that of the 33 patients with drug-resistant generalized epilepsy, 5 became seizure-free with valproate. So that means of those who were resistant to valproate, none became seizure-free. So unresponsiveness to valproate has 100% specificity and 100% positive predictive value for drug resistance. So that means that for, somehow valproate seems to be the drug of choice for genetic generalized epilepsy. And that's those patients who did not respond to valproate did not respond to any other medication. That's the message that that this paper gives. And I think in clinical practice, we have also seen that happen all the time. But again, there's a concern, and I have to bring this back. There's a very high price that sometimes these, we women pay for this. The risk for malformation is about 10%, autistic spectrum. So, childhood autism, autistic spectrum disorder, all these things, the absolute risk is definitely higher. There's no doubt, but that's also a dose. This is coming from our own Sri Chitra group, the KREP study, which clearly showed that there is a dose response effect for the rates of major congenital malformations for valproate. And if you use lower doses, then it is actually much less. And as you use higher doses, definitely the adverse effects, the teratogenicity potential is much higher, without a doubt. And this is a very interesting point. And you can see here that you just concentrate on this I, J, and K. That is valproate. H is valproate monotherapy. That is, so it's not, at least in our population, it was about this much. Then you see that polytherapy without valproate, this one, polytherapy with valproate, low dose valproate, polytherapy with high dose valproate. So obviously, any polytherapy, it's going to increase. When valproate is added to the polytherapy, then obviously there's a much higher risk. But then, so because of the dose effect, if you use very small doses, and in many of the genetic generalized epilepsies, valproate dose can be quite low. They don't require that much at all. And many of our patients do very well with just 300 milligram or 400 milligram, sometimes even 200 milligram a day. So that's something that we do. The commentary on SANAD 2, this is interesting. It just came in Epilepsy Currents. Dear levetiracetam, the honeymoon is over. In generalized and unclassifiable epilepsies, levetiracetam is less efficacious than valproate. Even for focal epilepsy, levetiracetam is inferior to carbamazepine, lamotrigine, and zonisamide, the SANAD 2 arm A. And although it's user-friendly, it's not the most effective of anti-seizure medicine. The honeymoon bliss is over, but it's still a very good choice for women with epilepsy when they're considering pregnancy. So I think there is definitely a role for that. And it's without a doubt, valproate is more efficacious and more cost-effective than levetiracetam for genetic generalized epilepsy. However, we have to be very, very cautious. And in Europe and in the Western countries, now they have banned the use of valproate in the women of childbearing age. Not only women of childbearing age, but they have also said that you should not use it in women at all at any age. I think that's a little, I think it's a bit of an extreme step, but I don't know. I mean, this is something that we have to debate. Because our KREP study also has shown that in small doses it can be used. So thank you very much for your attention. And I think I've kind of laid the argument for the use of valproate in a large number of people. Valproate in moderate doses is very effective for genetic generalized epilepsies, and it clearly outscores levetiracetam for almost all the groups except for women in the childbearing age group, where we have to be very careful. So thank you very much.
Which
Thank you,
forms
sir.
a major group.
Yeah, I think we have taken your point, Dr. Jayanti. So that is, I think both of you have debated well, and the major point which I think Before beginning the discussion, I think we'll take the poll again. So can we have the poll now after the debates, whether there is any change or not? Admin team,
Hello.
can we launch the poll?
Yeah.
Same. Okay, so please, same question and same options. Please vote for 10. We'll give you 10 seconds, and after that, we'll display the results.
Should I display?
Yes. Okay.
Yeah, it's
It's increased.
Okay. So Valproate has been increased. The question is formed like that. These are unselected patients with genetic generalized epilepsy. I think what points which has been made that as of now, there is no doubt that Valproate remains the most effective drug for the patient with genetic generalized epilepsy, although it has major problem in women of childbearing age. And then there is a doubt whether the Valproate produces more side effects as compared to the levetiracetam. So those are the issues, I think. We have two senior panelists, Murthy sir and Gagandeep sir. So we will take their opinion. Okay, I think we can start with Gagandeep sir. Sir, what is your take on this debate, and based upon your experience, and what is your take and how do you go about this?
Thank you. I must first of all congratulate you, Dr. Rathore, for bringing this up for this discussion, and both the speakers who were really excellent, very eloquent, and I mean they really quoted data which speaks for itself, but the way they brought forward the case for both the drugs, levetiracetam and Valproate, was excellent. I do have to say that there are advantages and disadvantages, and the advantage, I think what Dr. Jayanti emphasized for levetiracetam is the ease of use. Why is it so often used by people who are not even neurologists? Non-neurologists, non-specialists are so happy. There are no interactions, there are no major side effects apart from irritability and anxiety, and the few psychiatric side effects. Does not cause a drug rash. It has an immediate onset of action. You don't have to worry about so many other things, protein binding and drug levels and so many things like that. So the major advantage of levetiracetam, I think, is the ease of use. The other thing, again, which Dr. Naik brought up, is the dose of levetiracetam. And I have always, whilst interpreting the Senate 2 trials, the dose of levetiracetam with which they began was 500 twice a day, which I think is a slightly lower dose in comparison to 500 milligrams twice a day for Valproate in idiopathic or genetic generalized epilepsies. So I think that also could have to do. And then when we look at what is the difference in, for instance, time to seizure remission, whether it is 12 months, 24 months, how much is the difference? Is the probability difference is not too huge. It's about 9%, 10%, 12%, I think. So it's really not huge. So I think both are good drugs. There is no doubt. I mean, there is evidence now to suggest that Valproate has better efficacy, slightly better efficacy than levetiracetam. I mean, I'm talking about clinical difference and not the statistical difference. However, still to my mind, the most important consideration in choosing a drug are the patient characteristics. So, and there are a huge list of patient characteristics. Patient might be obese, patient might be thin, patient might be women in the reproductive age group, patient might be, the person might be elderly, might have renal stones, might have comorbid cardiovascular disease, might have comorbid cancer. So there are huge number of patient characteristics, and eventually, I think more important than efficacy in most patients. Some patients where one drug does not work, levetiracetam most often, then you need to think about introducing valproate in that kind of situation. But in most situations, rather than efficacy, it is the patient characteristics which determine our choice of drugs, and these are of paramount importance. So I think these are some of the thoughts that I have, but I must really say that both Dr. Jayanti and Dr. Naik, you took forward your respective cases very well, and it's an excellent discourse of the actual data that is available now, and we have good amount of data. And the other thing is, if you look at some real world studies, and there are some real world studies which have come up, and these studies have emphasized let's say it's a woman with epilepsy who's already on valproate, and now we have all these this kind of information and the regulatory issues. This was debated in the British Parliament, and the British Parliament, this valproate issue was debated in the British Parliament. And despite all of this, and despite all the information, many of the women with epilepsy who are well controlled on valproate choose to continue taking valproate and not switch to levetiracetam or any other drug. So that's also something we must keep in mind. So these are some of the thoughts that I had. But again, very well discussed. Thank you. And it was great learning. Yeah.
Thank you, sir. So for your insight, I think sir has made 3 points, and I will bet for on the behalf of Naik, sir. One is the ease of use of levetiracetam versus valproate. Now, as far as ease of use is concerned, I don't think there is a much difference between levetiracetam and valproate. We are not talking about phenytoin or carbamazepine or sodium channel blocker. Similarly, the drug interactions, valproate doesn't have any major drug interaction as compared to other sodium channel blockers. So those points, although are valid, and secondly, thirdly, about the side effects, because it has there is a general perception among even the epileptologists and even the neurologists that valproate produces more side effect as compared to the levetiracetam and disabling side effects. But that concept or that concern has been effectively answered by the SANA-2 trial, which shows that there is no difference between the side effects. So as far as this is concerned, I think, and once you ask that there is a 9 or 11% difference between the efficacy, why you want to give those 9 and 11% patient another seizure, which can be a major problem? Generalized seizure may cause a major multiple issues and this. So those points, I think we'll have to consider, and efficacy remains the most important thing when you choose the medicine. Obviously, there are patient characteristics and other things matters. Murthy sir, your views on that?
I agree with Dinesh that valproate is the most effective drug in patients with genetic generalized epilepsy. And as you have said, the side effects except malformation of major congenital malformation, the side effect difference between the two is almost similar, as shown in SANA-2. And SANA-2, we don't have still the data on the efficacy or side effects of sodium valproate versus levetiracetam on pregnancy. So still that data, they are not released. So we otherwise, sodium valproate is the most effective drug in patients with genetic generalized epilepsy. The side effects, except for major malformations, is almost similar. And as you have said, the efficacy, the few percentage this way, that way, is not much important. But as far as I'm concerned, sodium valproate is the most effective drug in genetic generalized epilepsy.
So, sir, apart from the women of childbearing age, which drug you use? Do you use valproate as the first line?
I use a valproate as first.
Okay. Soham, you want to?
Yes, sir. So what I wanted to highlight was that when we talk of treating patients, we have two ways. One is precision medicine, which experts like us and even our epileptologists would do. As what Dr. Gagandeep was saying, that select these characteristics and then choose one drug. But the question we are discussing here is more at field level. So like not we are splitting the patients according to comorbidities, but lumping them together. And that actually is a big issue in patients in epilepsy. As the WHO and ILA program says, the paper, Dr. Gagandeep also is one of the authors, the Global Action Plan Against Epilepsy. So I think they say that there are 4 pillars of epilepsy care, especially in rural and underdeveloped areas and developing countries, like one in India included. So major problem is the treatment gap. So patients are actually not educated enough to take a medicine. Second thing is the primary care giver. They are not having the education to give. And the third they say is that we can use innovative technology, digital technology, so that a distant neurologist can just guide treating epilepsy in the rural region. And fourth is they say make the other newer drugs available in the WHO model. So levetiracetam unfortunately is still not available in the WHO essential medicine list. So I think we have both Dr. Murthy and Dr. Gagandeep who are like involved in our national guideline making things. So what I suggest is, can we, rather than making it complicated so that patients are not even able to reach neurologists often in rural India. So if we can have a guideline where primary care doctor or ASHA workers are given an authority, they can be taught about the simple concept of focal versus generalized. And for females, we make
Soham, we are deviating from the topic, I think.
No, it is the same topic. So
No,
what I'm saying is, for
are-
females we give levetiracetam, for males we give valproate. And I think the debate ends. We both, if I say that, both Dr. Nayak and Dr. Mani would agree.
No,
For
see,
all males we
when
use
we
valproate, for all females we use levetiracetam. We
no,
change the question a bit.
No, see, when we talk of women, only women are not in the childbearing age group. They are the women who have, there are many patients of genetic
So
generalized
after
epilepsy.
55, 60, sir, what female, generally most JE would be
No,
in
what by
relation,
50?
sir.
If they complete their reproductive life after 30, 32 years, why you cannot use valproate, which is the most effective drug?
But often they don't undergo tubal ligand surgeries also. We have patients who have
So
pregnancies even
you
at
have
45.
female patients who have completed their family, and those will be equally half of the patient with genetic
But if
generalized
they have not
epilepsy.
undergone tubal ligation, or the male has not undergone, would you still prefer to give valproate?
If they are very sure that they don't want a child, or they have completed their family, I'm giving valproate. I'm using it.
No, that
Because-
you are a different person. I'm talking about an uneducated average Indian person in rural community.
No, so thing is different, Shom. When you talk of the primary care, the things are different. And even in the primary care, I think advocating the use of levetiracetam as a drug of first choice may not be very great, where you have to discuss about the cost effectiveness also.
So in our, like what I say is, in India, somebody who has an advanced malignancy on palliative radiotherapy, our government programs give it free. Right, but when somebody, young male or female, has epilepsy, just some drugs, single drug per day with minimum cost, and his life completely improves. Our government doesn't provide it. So
Yeah, I
I
agree.
like to hear
Those
Dr.
are the
Gagandeep sir,
What
issues.
do you
or Dr.
think? I
Murthy's
think
views on that.
you are advocating more of a primary care and generalizability of these findings. So I think that
Because
can.
No,
this
but
is
there
not
is a
discussion.
point in what he's saying, because we think as neurologists we are all treating epilepsy, but I think a large proportion of epilepsy is being dealt with at the primary care and even at the physician level. So this is the reality. So I think that point is well taken. I mean, the rest of it, of course, can be debated as to, and it's individual choice based on precision and selecting but making this available, I think, is a point not as part of the debate, but something if we can do, it would be really good.
I think those are more broader issues, which probably is not in the purview of the topic which we are debating as of now. Okay. So I agree with and
Because there is
is
a
the
real
cost
world,
is
there is a real
would,
world, and there is an artificial world of,
That is-
science.
correct.
There is a practical
True.
world.
No,
So
I
I
want to
showed you the
confirm.
data from India, which is
Yeah.
done in 4 centers. And if you see, it's still in generalized epilepsies that double the number of patients are on levetiracetam compared to valproate. This is not
Yeah.
my data, it's from 4
Sure.
different centers. Yeah.
Yeah,
See,
so with the
people use
increased risk of
levetiracetam quite a
seizures,
lot.
so those patients are on more patients are on levetiracetam as compared to valproate with a higher risk of seizure they carry. So
Yeah,
that
that
would be
We
is
are
what-
talking about initial monotherapy. Once they fail a drug, we are going to change. I mean, that's understood. But
so
that,
even so that is the whole point. No, even in the initial monotherapy, you have a 10 to 12% difference between valproate and levetiracetam. Why
in
you
a
would
study
want
where
to expose
levetiracetam was
those?
given underdosed, sir.
Why
Sorry?
in those 10 to 12%
In
patients
Senate
you
2,
want?
levetiracetam initial dose was underdosed, as
absolutely
Dr.
right.
Mani showed.
No,
Just one
not
second.
really, because I'll tell you why it is not underdosed. If you look at I'll just take what Dr. Jayanti had emphasized in the, she said that 26% of the patients were below 12
Absence.
years.
Absence
And
epilepsy.
yeah,
So that is one. And for them, the dose that was given was 40 milligram per kilogram, which is,
No,
I
but-
think, half of the course.
No, but
And
we
I
know
think
that
it's
absence
perfectly fine.
epilepsy doesn't do well with levetiracetam. I showed you that data. Only 25% do well. If you
Sure.
misrepresent and put so much of absence, levetiracetam is not going to do well
I
because we
think
know it
Dr.
doesn't work well.
Jayanti and Dr. Nayak, sir, you have already debated that point and everybody has heard that. Now, thing is, as far as the dosing is concerned, it is not the time to first seizure. There is a time to treatment failure also. And the time to
That's true.
treatment failure when the dosage were adjusted for both the drugs.
Adjusted, yeah, that's what.
The
It is
patient
not
has
just
reached the
that-
maximum tolerated dose when the clinician decided that this drug is not working. That was the outcome point. So
But
it is
can
not
I-
the initial dose.
Yeah, that's true. Absolutely.
No, but
true.
I just want to make a point here that when we adults are discussing epilepsy or generalized epilepsies, I don't think in any cohort of generalized epilepsy there is 26% of absences when there are 13% of JME. That is not happening, which is what was the cohort. So with all due respect to this study, there were some aspects which were skewed for valproate. I'm just bringing that out. I'm not saying.
Not really, because 45% of the patients actually had idiopathic generalized epilepsy, not otherwise defined. And it didn't fall into JME, it didn't fall into absences. It was a large group, 45% in adults. So I think it's still a representative group. I agree that 25% is pretty high, but the only thing that was less represented was actually JME. That is there.
No, so
But
that's-
there was enough adults who had, 45% of them were idiopathic generalized epilepsy, where they could not actually pigeonhole it into
Sir,
JME.
madam, you have already discussed these points. So now to take forward, everybody has got those points. I think we'll have to see once you talk of this absent seizure and this absent seizure is generalized seizure, that again shows that valproate is more effective in
Correct.
genetic generalized epilepsy. What is the
No.
point to differentiate?
So what we talked in EBM is
One
test
second.
effic-
One second. I
Yeah.
think Dr. Shailaja is also there. She was in epilepsy for long period, so we can take her comment
No.
also.
I think it was a very good debate. It was an excellent debate, actually, because since we are away from epilepsy, it was a good learning for me also. But few points, as has been clearly highlighted, is very clear. Valproate is definitely more efficacious. There is no doubt about it. We all have seen also it to be very effective in patients. But when it comes to childbearing group, even though Rathod had mentioned situations where always we tend in females not to give it, so that feeling is there always in our mind about not giving the valproate in those patients. So I think it's a precision medicine. You make your decision depending upon the patient characteristics and finally decide. Thank you.
Good point.
Okay, so I think probably we have taken the views and this to summarize, it clearly stands out that valproate is the most effective drug. There is no doubt about that. So as far as I think everyone will agree. And this is if I start a patient, even a female patient comes with a generalized epilepsy, and I start levetiracetam, I have some doubt in the back of mind that this may not be controlled. So this is a clearly clinical experience which has shown, and this has been proven that valproate is the most effective drug. Problem is only in the women of childbearing age, where levetiracetam, or probably we are highlighting only levetiracetam, because there are other drugs which may be more efficacious than levetiracetam in women of childbearing age. For the example, lamotrigine. In the SANAD 2 trial in focal epilepsy, lamotrigine was clearly superior to the levetiracetam. So in that case, in women of childbearing age, please, let us not restrict to the levetiracetam alone. That message should not go that levetiracetam is the drug of choice in genetic generalized epilepsy in women of childbearing age. Obviously, valproate cannot be used, but there are other options apart from the levetiracetam. Third option, which I want to highlight, that there are women in the childbearing age group who can be controlled only with valproate, and this I think everybody must have seen it. There are the women who cannot be controlled with levetiracetam and lamotrigine, and you have to give valproate. So there are, obviously we all understand what are the pros and cons and discussing with the patient and precision medicine and what needs to be discussed with the patient. And giving all the risk-benefit ratios and everything. But there is a group of patients, and I have multiple times we come across the patient when you switch over from the valproate to levetiracetam, seizure control worsens, or they get generalized seizure. And I have many examples. Then the patient themselves have switched over to valproate by themselves before coming to us that this drug was not working. So these are the certain points I think we have to keep in mind before deciding what is the optimal drug. But obviously, depending upon the patient characteristic, we need to determine. But if you give a factor of unselected patients without any characteristic, as far as efficacy is concerned, and for that part or the other profile, at least I feel, and this is the data about that valproate remains the most effective drug and drug of first choice. If anybody else has any...
There are 3 questions. I don't know. Can we take it here in this format, or we may not? There are 3 questions in the audiences. One is, can we extrapolate this condition, these conclusions to brivaracetam? That second is, cognitive slowing and decline is not acceptable with valproate. And third question is, what about medical legal issues using valproate in female? Maybe somebody of you all experts can talk on these issues. These 3 questions are there.
Yes, Nayak sir, you want to take brivaracetam versus levetiracetam?
No, I'll take that second one. That's cognitive slowing, and in what is the patient or is in the offspring of the what is?
That's not
we don't know.
I'll
answer. I mean, obviously, cognitive slowing is there. We that in patients on valproate, I don't think there's any cognitive slowing at all. In fact, because the doses that we use, you see, the one of the things that we have to understand as clinicians, which we are treating for many decades now, we have learned to understand that these initial monotherapy in patients with genetic generalized epilepsy, you take childhood absence epilepsy, you take juvenile myoclonic epilepsy, you take generalized epilepsy non-awakening or whatever it is, or just generalized tonic-clonic seizures, and they have generalized fast spike and wave discharges. In those groups, the requirement of valproate invariably it doesn't exceed 400 milligram per day. It's a small dose, and many of them will require only 200, 300, majority of them. Very few of them will require higher doses. And in those patients who require higher doses, they don't do very well on, 3 grams of levetiracetam for sure. They're not going to do very well on other drugs also. So, we are talking of a condition which is very easily treatable on small dose of medicine, which doesn't have any cognitive effects unless there's some idiosyncratic reaction. That's it.
Okay, sir. Your point is well taken. As far as brivaracetam and levetiracetam is concerned, overall efficacy-wise, I don't think any problem. But we have to understand that brivaracetam has not been studied in women of childbearing age as of now. And we cannot extrapolate the results of levetiracetam to brivaracetam in women of childbearing age. See,
Hello?
this thing which is true for the, if you compare carbamazepine and oscarbazepine, both are same drugs with some prodrug this. But if you see the teratogenicity of carbamazepine, oscarbazepine, there is a difference. And the oscarbazepine has a lower teratogenicity as compared to carbamazepine. So same thing might be hold true for levetiracetam, levetiracetam. We don't know. So unless there are results and the more data comes out, as far as I am concerned, women of childbearing age, we should use, if at all we are using one of this levetiracetam, brevacetilam, we should stick to levetiracetam. That will be my opinion. Third
Can
part,
I
as
add-
far as the medical legal issues concerned, this India, this situation is very dicey. Whatever the recommendation of the international agencies there, that if you are using valproate is not banned to be used completely in women with epilepsy, although in psychosis and bipolar disorder it has been banned. So in those group, you have to clearly explain that people or the patient and the doctor have to sign the form and then explaining all the pros and cons, and they understand that they are taking this valproate, and probably they also has a clause that they will be using contraceptive while using valproate. So this form has to be signed, specific form in Western countries. India, as of now, there is no guidelines, but I don't know what will be your views on, sir, Murthy sir.
Because I still, as I said, sodium valproate is my choice because it's most effective drug for generalized genetic epilepsy. And the other group which we are not discussing is about 1/3 of the patient with CME will have absence seizures. They don't respond to levetiracetam. And third thing is the comparison the brevacetilam with levetiracetam. We don't have much data on various parameters in regard to brevacetilam. So I don't think we have to compare them at this juncture as we don't have much data.
Okay, sir. I think we have highlighted all these points, and can we have one last poll? Let us say after the discussion, if there is any change. Admin, please, can we have the last poll before closing it?
Chaturbuj, you have voted so much for valproate, it is going to become 100%.
Because that is what I am practicing.
We all use levetiracetam. It's good for point for discussion. So it's very interesting.
No, it's going to become 100%, I can tell you.
No, certainly not.
So please vote in this. And
No, but still panelists and hosts cannot vote, otherwise I would have given 5 votes.
I would have cross
okay,
voted.
we can show the results, please.
Because your points were very, very, very nicely debated, actually.
See,
Okay.
I told you.
Oh my God.
See, so the coordinator, or what we call the moderator, has been able to swing the results 91% for the valproate.
And you can
I
take
think
all the
All our
credit.
fans of Dr. Rathore.
Thank you very much, madam, for excellent debate, Naik sir. And I think Intas has been supporting us as a for logistic, and they have initiated this program. I will invite Mr. D'Souza for the vote of thanks.
Good evening, doctors. At the very onset, I would like to thank the speaker, Dr. Dinesh Naik and Dr. Jayanti Mani, for participating on the online debate titled Initial Monotherapy in Patients with Genetic Generalized Epilepsy, Valproate versus Levetiracetam, when they have vociferously justified their stance for the role of valproate and levetiracetam respectively. I would also like to thank the valued contribution of the expert panelists, Dr. J.M.K. Murthy, Dr. Gagandeep Singh, Dr. Soham Desai, and Dr. Saileja, who all being stalwarts in their own field, have added their rich clinical experiences to further augment the benefits of today's debate. My heartfelt gratitude to Dr. Chaturbuj Rathore as well, who not only moderated excellently today's program by summing up the salient features of everyone's talk, but he has been the silent force in organizing today's webinar and the subsequent series of controversies to consensus. I would like to thank the online participation of more than 200 doctors who are present for today's webinar, without which this program would not have been a success. A big thank you to you all, and looking forward to all of you in our next session every second Friday of every month, which would mean 12th of May next month. Thank you very much. Good night to all of you.
Can I ask one question?
Yes, sir.
When is the data about pregnancy and valprate and SONAR2 data will be out?
I don't know, sir, because
Sir,
they have
there were no
already,
patients.
there
There
were
no
only
patients.
8 or 9 deliveries and
Nine.
all were in levodopa
Nine,
system.
all are
Yes.
levodopa. So
All were
there's
good.
no pregnancy. Yeah, that's
So
true.
they already told in that, sir, paper. Okay, sir. Thank you very much, Jayanti
Thank
madam,
you.
Naik sir, Murthy sir,
Thank you
Soham.
very much.
Thank
Sanjay
you,
Prakash, everyone.
Chaturbhuj, and thank you to all the panelists. Yeah.
Thank you.
Thank you,
madam.
Intas.
Thank you.
It has been excellently arranged, and I think we had a good
Yeah.
participation. Thank you very much.
Thank you very much. Thank you so much.
Excellent,
thank you.
It's unique
excellent.
format.
So
Thank you.
so-
Thank you, sir. Thank you from
so much.
Intas.
Have a good weekend all.
Thank you, sir. Thank you.
Good. Bye bye.